This video will focus on an experimental study design, specifically a randomized controlled trial. Randomized controlled trial is designed to investigate cause and effect relationships between variables, which is a key strength compared to observational designs. As shown in the figure, the process begins with recruiting participants. Once participants are enrolled, they are randomly assigned to different conditions. Typically, this includes an experimental group and a control group. Randomization is critical because it helps ensure that the groups are comparable at baseline and reduces selection bias. Each group receives a different treatment. The experimental group receives the intervention of interest, while the control group may receive no treatment, usual care, or a placebo. A defining feature of RCTs is the manipulation of the independent variable. In other words, the researcher actively introduces the intervention. The intervention period can vary depending on the study design. It may last for days, weeks, months, or even years. Because participants are followed over time, RCTs are considered longitudinal studies. To evaluate the effectiveness of the intervention, outcome variables are measured in both groups. These measurements are typically taken at baseline, before the intervention begins, and again at the end of the study. Finally, researchers compare the changes in outcomes from baseline to post-intervention between the experimental and control groups. If the experimental group shows significantly greater improvement, this provides evidence that the intervention is effective. Now, let's discuss the advantages and limitations of randomized controlled trials. One major advantage of RCTs is randomization. By randomly assigning participants to groups, important characteristics such as age, gender, and motivation are expected to be evenly distributed. This helps minimize the influence of extraneous variables and strengthens the study's internal validity. Another strength is the high level of control researchers have. Because the independent variable is manipulated, investigators can design different levels of intervention, such as high, moderate, and low-dose exercise programs. This makes it possible to examine dose-response relationships. However, RCTs also have several limitations. One common issue is participant dropout. Some individuals may be disappointed with their group assignment. For example, wanting to be in the intervention group but being placed in the control group. Others in the intervention group may drop out if the program feels too demanding. RCTs are also time-consuming and resource-intensive. They often require multiple measurements over time, including baseline and follow-up assessments, and may involve complex interventions that require a full research team to manage. Recruitment can be challenging as well. Because RCTs typically have strict eligibility criteria, researchers may need to screen many individuals to recruit a relatively small sample. This can significantly slow down the study process. Generalizability is another concern. Participants who meet strict criteria and agree to join the study may not fully represent the broader population, which can limit how widely the findings can be applied. Compliance is also an issue. Participants may not follow the study protocol as intended. For example, individuals in the control group might change their behavior, while those in the intervention group may not fully adhere to the program. Finally, dropout can disrupt the balance created by randomization. If participants leave unevenly across groups, the groups may no longer be comparable, which can introduce bias into the results. To better understand how a randomized controlled trial works, we will use the Project Active study as an example. Project Active was a randomized clinical trial funded by the National Heart, Lung, and Blood Institute. This study aimed to examine the effectiveness of different approaches to promoting physical activity. This study was led by Stephen N. Blair, who served as the principal investigator and is a well-known researcher in the field of physical activity and public health. Using this study, we will walk through the key components of an RCT, including recruitment, randomization, intervention design, and outcome evaluation. The premise of Project Active was based on an important observation in physical activity research. Traditional methods of prescribing exercise, such as giving individuals structured exercise plans, have generally not been very effective in helping people both start and maintain regular physical activity over time. While these approaches may work in the short term, many individuals struggle with long-term adherence. This suggests that simply prescribing exercise is not enough to create sustainable behavior change. Because of this limitation, Project Active aimed to explore alternative strategies that focus more on lifestyle-based physical activity and behavioral approaches, rather than relying solely on structured exercise programs. Project Active was a 2-year intervention study. It included 6 months of active intervention, followed by 18 months of follow-up. While cohort studies may last decades, a 2-year randomized controlled trial is already considered quite long, especially when managing a large number of participants. The study compared 2 groups, a lifestyle physical activity group and a structured exercise group. We will go into more detail about these approaches in the following slides. Participants were recruited in 3 separate cohorts and randomized at 6-month intervals. This means that 1/3 of the participants began the study first, receiving the 6-month active intervention, and then entering the 18-month follow-up period. After that, the second cohort began their intervention, followed by the third cohort. Because of this staggered design, the entire study took about 4 years to complete, from August 1, 1993 to July 31, 1997. At the end of the 6-month intervention period, both the lifestyle and structured exercise groups showed significant and similar improvements in physical activity levels and cardiorespiratory fitness compared to baseline. However, the long-term results tell a different story. After 24 months, participants in the structured exercise group had returned to baseline levels for both physical activity and cardiorespiratory fitness. In contrast, the lifestyle group maintained their improvements. After 24 months, their physical activity and cardiorespiratory fitness levels were still significantly higher than baseline, and also significantly higher than those in the structured exercise group. Eligibility criteria for Project Active included men and women aged 35 to 60 years. Participants had to be sedentary, non-obese, living in the Dallas-Fort Worth area, and apparently healthy. Apparently healthy was defined using several screening criteria to exclude individuals with potential health risks. This example shows that RCTs often have strict inclusion and exclusion criteria, which increases the complexity of recruitment. This is a participant flow diagram, also known as a consort diagram, based on the Consolidated Standards of Reporting Trials. It shows enrollment, group allocation, follow-up, and analysis in the trial. In this study, 313 participants initially showed interest. Of those, 237 met the eligibility criteria, and 235 were ultimately included and randomized. The gender distribution was roughly equal across both groups. By the end of the study, 190 participants completed the trial. The consort diagram also lists the main reasons for dropout, which helps us evaluate study feasibility and identify potential sources of bias. The goal of the study was to increase energy expenditure to 3 kilocalories per kilogram per day in both intervention groups. For context, about 3 kilocalories per kilogram per day is roughly equivalent to 30 minutes of moderate intensity exercise on most days of the week. At the time of the study, there were no formal physical activity guidelines in the U.S., so this target reflected the best available recommendations. As a result, the study goal was set slightly higher than what would later become standard exercise recommendations. I assume many of you have taken an exercise psychology course and are familiar with behavior change theories. In this study, the trans-theoretical model was used to guide the intervention. This model includes 10 processes of change, 5 cognitive strategies that focus on changing how people think, and 5 behavioral strategies that focus on changing actions. Let me ask, who here has experience with behavior change? What were your thoughts? In general, we know that human behavior is complex and difficult to predict. People often face barriers that prevent them from taking action. Also, simply having knowledge does not necessarily lead to behavior change. Motivation plays a key role, especially intrinsic motivation, but it varies widely across individuals and does not always guarantee sustained change. In the structured intervention group, researchers used a traditional exercise prescription model. Participants were prescribed exercise at 50% to 85% of their maximal aerobic capacity for about 20 to 60 minutes per session. They attended supervised exercise sessions at a fitness facility, offered 5 days per week for the first 6 months. Initially, participants were asked to attend at least 3 sessions per week, gradually increasing to 5 days per week. During the 18-month follow-up period, support was reduced. Participants met quarterly for group activities and received a monthly activity calendar, along with a quarterly newsletter highlighting the benefits of physical activity and related research findings. Participants in the lifestyle intervention group were encouraged to accumulate at least 30 minutes of moderate intensity physical activity on most, preferably all, days of the week. They were guided to progress toward this goal based on their readiness to change, rather than following a fixed prescription. During the first 6 months, participants met in small groups for 1 hour per week for the first 16 weeks, then bi-weekly until week 24. These sessions focused on cognitive and behavioral strategies to support physical activity. Unlike the structured group, they were not given free access to fitness facilities. Meetings were held in classroom settings. During the 18-month follow-up, meeting frequency gradually decreased, from monthly to bi-monthly, and then to every 3 months. Activities included group-based events, such as mall walking, orienteering, volleyball, and interactive games designed to reinforce behavior change skills. Participants also received a monthly activity calendar and a quarterly newsletter. The primary outcome measures included physical activity and cardiorespiratory fitness. Physical activity was assessed using energy expenditure, while cardiorespiratory fitness was measured by peak oxygen uptake, or VO2 peak. Secondary outcomes focused on cardiovascular disease risk factors, including blood pressure, blood lipids, and lipoproteins, as well as body composition. Now let's look at some results together. The authors compared energy expenditure across different intensity levels. From the figure, we can see that the lifestyle group showed a greater increase in moderate intensity physical activity. In contrast, the structured group showed higher increases in hard and very hard activity levels. All of these differences were statistically significant, with p-values less than 0.0001. The next two slides show individual changes over time in energy expenditure and peak oxygen consumption, from pre to post-intervention. Each bar represents one participant. In the structured group, there was a high level of variability in individual responses at 24 months. For energy expenditure, changes ranged from a decrease of about 5 to an increase of about 8 kilocalories per kilogram per day. For peak oxygen consumption, changes ranged from a decrease of about 7 to an increase of about 13 milliliters per kilogram per minute. This highlights that individuals respond very differently to the same intervention. Now, how about the individual responses in the lifestyle group? The variation is less extreme compared to the structured group, but there are still substantial individual differences. Most participants showed changes in energy expenditure between about -4 and 7.5 kilocalories per kilogram per day. However, there were a few outliers. One participant decreased by about 10, and another increased by about 14. For peak oxygen consumption, the range was also narrower than in the structured group, roughly from -5.5 to 11 milliliters per kilogram per minute. So what explains this variation? It could be due to both physiological and psychological differences. For example, some individuals may be more motivated, have higher adherence, or be more engaged with the intervention. Factors like baseline fitness, personal barriers, and consistency in participation can all contribute to differences in outcomes. Now let's look at the clinical outcomes. In terms of body weight, there was no significant change in the lifestyle group, and the structured group even showed slight weight gain. Overall, there was no meaningful difference compared to baseline. Is this surprising? Not really. This was not a weight management study, and diet was not controlled, so large weight changes were not expected. However, when we look at percent body fat, both groups showed significant reductions at 24 months. So how do we interpret this? If body weight stayed the same, or even increased, but body fat percentage decreased, it suggests that participants likely gained lean mass, such as muscle. In other words, body composition improved even without weight loss, which is an important distinction when evaluating health outcomes. In conclusion, both the lifestyle and structured physical activity interventions led to improvements in physical activity and cardiorespiratory fitness over the 24-month period. However, the lifestyle approach appears to be a practical and effective alternative for helping individuals meet public health recommendations. These findings suggest that flexible, behavior-based strategies may support more sustainable long-term change. Future research should continue to test lifestyle approaches in different populations, settings, and delivery methods. Next, we transition to discussing a single-group pre-post study, another type of experimental study design. This is not required in this class, but I would you gain a little bit concepts on this. This diagram is similar to a randomized controlled trial, but it represents a single-group pre-post study design. In this case, all eligible participants are assigned to one group, the intervention group. There is no control group for comparison. Outcomes are measured at baseline and again at follow-up, similar to an RCT. Researchers then compare the change in outcomes from baseline to follow-up to evaluate whether the intervention had an effect. Here is an example of a pre-post study design using a chatbot as the intervention. This is the flowchart of the study, which summarizes the recruitment and participation process. A total of 99 individuals initially showed interest, but only 31 met the eligibility criteria. Common reasons for exclusion included being too young, too physically active, or already following a Mediterranean diet. All 31 eligible participants received the 6-week intervention. This included a computer-based individualized introductory session, weekly check-ins and goal setting with the chatbot, and 24/7 chatbot access. Outcomes were assessed at post-intervention and again at follow-up. By the second follow-up, 28 participants remained in the study. This type of flowchart helps clearly present the entire recruitment and retention process to the audience. Let's summarize the study designs discussed so far. Here are the key differences between randomized controlled trials, cohort studies, and cross-sectional studies. From a time perspective, both randomized controlled trials and cohort studies are longitudinal. They follow participants over a period of time. In terms of measurement, RCTs focus on outcomes. Participants are assigned to different groups, and researchers compare outcomes between groups to evaluate the effect of an intervention. In contrast, cohort studies typically follow one population over time. Participants are classified based on exposure status at baseline, and researchers compare the incidence of disease between exposed and non-exposed groups. Cross-sectional studies are different. They assess exposure and outcome at a single point in time, so they cannot establish temporal relationships. Now let's compare study designs in terms of cost and validity. Observational studies, such as cross-sectional, case control, and cohort studies, are generally less expensive and easier to conduct. However, they may have lower internal validity. because researchers cannot control for all confounding factors. In contrast, experimental studies like randomized controlled trials are more expensive and resource-intensive, but they provide higher validity, especially for establishing cause and effect relationships. The evidence pyramid shows the strength of evidence provided by different study designs. At the base, animal and laboratory studies provide important background knowledge but have limited applicability to humans. Next, case reports and case series describe individual or small groups of patients. They are useful for generating hypotheses but cannot establish causality. Moving up, case control and cohort studies, along with randomized controlled trials, are considered primary studies. Case control and cohort studies provide stronger observational evidence by identifying associations between exposures and outcomes. Randomized controlled trials offer even stronger evidence because they are designed to test causal relationships. At the top of the pyramid, systematic reviews and meta-analyses synthesize results from multiple studies, often RCTs, to reduce bias and provide the strongest evidence for clinical and public health decision-making. Here is a summary of the main study designs we covered in this section. Please take a moment to review and compare the key characteristics of each design, including their strengths and limitations. This summary should help you better understand how different study designs are used in research and how they contribute to the overall evidence base.